I found that session very interesting because it really has a lot of relevance to our current practice. I mean, the first issue was the definition of triple-class refractory, which of course is the fact that a patient is refractory to a proteasome inhibitor, immunomodulator, as well as an anti-CD38 antibody. I think the person who chaired the session, who also summarized some of the main key information from the abstract presenters, was that it was probably more important to talk about the refractoriness to particular drugs rather than to class, because even though a patient could be refractory to 3 classes, and that's particularly important in jurisdictions like ours, where we don't have all the drugs that other jurisdictions might have, for instance, CAR-T and bispecifics, not all of them anyway. We do still tend to rely particularly on trying to choose drugs which a patient may come from a particular class, but a patient has not been refractory to yet as a result of exposure to other drugs in the same class. So to give an example, the patients who are carfilzomib refractory, we would often like to, who are proteasome inhibitor refractory, but not yet refractory to carfilzomib, even though previously exposed. We could use that again in combination, for instance, with pomalidomide or daratumumab or isatuzumab. So I think that point was made very clearly by Dr. Loniel, but in terms of the need to consider the actual drug rather than just a class. The other clear information that's come through is the very impressive results of the CAR-T studies and the T-cell redirectional agents. I think if we had access to all treatments with a broad armamentarium, it is very clear from the panel, from the presentations, as well as from the literature, that the drugs of choice would actually be CAR-T and T-cell redirectional agents. But I think also importantly, a question was asked, would you use CAR-T first or bispecifics first? And I think I did answer that question in the sense that the literature clearly shows that there are data indicating that if you use CAR-T, you would not then, hopefully, you would not sacrifice your subsequent responses to the bispecifics. Whereas there are clear data, for instance, from the CARTITUDE-2 study, which shows that even though the responses, if you use a T-cell engager first, the results from a CAR-T subsequently, even though may still be there, are lower. So those are very important take-home messages, I think. I also think it's important to remember why the CAR-T results are so impressive. If you think about the usual triple-class refractory patient, for instance, from the Mammoth study, the prognosis in general are, for instance, a progression-free survival of about 3 to 4 months, and then an overall survival of 9 to 12 months. But if you then look at the CAR-T studies, which were summarized and discussed, just taking the example of ide-cel, the PFS was 8.8 months and the OS was 19 months. So, and furthermore, with cilta-cel, at 27 months, the PFS was 55%. This is 27 months as opposed to the usual PFS that we are talking about of, say, 3 to 6 months in triple-class refractory. and the OS was 55%. Now, bearing in mind that the ide-cel KarMMa-2 study had 90% or thereabouts of triple-class refractory patients, and the CARTITUDE-1 study had approximately 78% triple-class refractory. So they are actually very representative of the types of results we would see with triple-class refractory patients. I guess the other thing I would very much like to highlight from the session was the very interesting presentation by Dr. Rashi from Germany about his investigations of the mechanisms of resistance to BCMA and directed agents in particular, but also GPRC5D immunotherapy agents. It was very interesting in the way that he showed that the deletions of expression, the loss of expression of BCMA in the resistant patients. But I did want to, I don't think there was a chance to discuss it, but prior to that, Dr. Ballas also discussed that there was evidence that there can be mutations in a particular domain of BCMA, which is extracellular domain. And as a result of that, it's not that the entire molecule is not expressed. It's the part of the molecule which has binding affinity to the BCMA-directed agents. And after the session, I actually discussed with him. So he and his laboratory has very good binding assays, which can be used to detect whether patients may have resistance to the BCMA agents, directed agents, before you actually utilize it. And more that could be a way of choosing the right drug for the right patient. I have to say, in talking about CAR-T, I haven't touched on the presentations about the bispecifics, but again, with teclistamab and tequaltamab and elranatamab, the teclistamab, I think is, about 77% triple-class refractory. Elranatamab is even higher, 91%. They are anti-BCMA agents, and, their response rates are around the 60% mark, and they didn't seem to be highly affected by the triple-class refractoriness, although it's looking them as a whole. And one thing that perhaps wasn't discussed as much, but I think alluded to, was obviously we have other antigens like GPRC5D for tequaltamab, and perhaps there may be a need to look at the use, the alternating of antigens or of targets to preserve the sensitivity in these refractory patients. I might say one point that I think was also brought up. I mean, the fact that our usual treatment armamentarium is now going to be quadruple therapy from the beginning. The fact is, triple-class refractory is now no longer late stage. There will be patients who are triple-class refractory early in the treatment course. And therefore, those studies which look at CAR-T or bispecifics early in treatment, such as CARTITUDE-4, KarMMa-3, they are really relevant. But kind of then bringing the whole scenario back to a jurisdiction like ours in Australia, where access to drugs it requires reimbursement as well as approval. I think we don't have the quadruple therapy from the beginning yet, but ultimately that type of scenario will be coming, and it behoves on us as physicians to try to utilize drugs, in a sensible, rational way. And so there's more and more kind of like movement towards trying to predict what patients would be sensitive or resistant to. And I was really kind of very interested to learn about those assays, which can be done in vitro to predict them, and to listen to those mechanisms of resistance, which were very interesting.